Good morning. Everybody take a seat. We'll get started. We are just a couple minutes behind, and my apologies. We'll do our roll call by way of self-introductions, so we'll start over here with Deborah.
Bell, Del Sol Medical Center and Border Rack.
Excuse me, Shirley, make sure everybody get as close as I am to this mic because we're being recorded and also the audience can't hear y'all. You almost have to swallow these things.
Okay, thank you.
Stacy Gregory, San Antonio Air Life.
Jan Cody, Care Flight.
Ricky Reed, Air Back Life Team.
Jim Spire, East Texas Medical Center, Air 1.
Alicia Wyron, Methodist Air Care. Alicia Wyron, Methodist Air Care, San Antonio.
And I am Shirley Schultz, Aero Care Lubbock, and other places, and the committee chair. So thank you all for being here this morning. This is being recorded, and thanks to the folks that have made that happen. Understand there's a storm on the way, so we'll not dally here and try to get through the meeting so that folks that need to get on the road can do that and stay safe. The first item on the agenda is the emergency health care recommendations for language inclusion and system development in Title 25 of the Texas Administrative Code to include acute care along with STEMIs and stroke to ensure the needs of patient care are met. We had some folks that were going to look at that and work on it a bit. Jan, I know you were part of that. Do you have a report for us?
Not really, because at the last meeting, we just decided that we would kind of table that until these rules came out and that we would just make sure that they were included there.
Okay, thank you. Number 2 on the agenda is a discussion of the language regarding patient care issues when EMS ground and air providers are present at the scene of a medical emergency. And I've been thinking about this, and I've come to the conclusion that this probably isn't really an air medical issue. I think the air medical folks know when they're in the back of an ambulance and they're taking care of a patient, that patient is theirs. The question seems to come more from the ground providers that have an air medical crew in their ambulance and something goes wrong and who's actually responsible. So I really feel like turfing this on over to the ground EMS folks is the right thing to do. And if they have the questions about it and have some issues with it, they know better what those are than we do. So I think we will take that off of our agenda, at least for now, and let the ground EMS providers pursue that. Any comments from the council?
Was this the issue of transporting a patient from a helicopter to the hospital?
More with fixed wing flights, I think, Jim, like from an airport to a hospital. But the air medical crew puts their patient in the back of an ambulance, and if something goes wrong with that patient, the rule states that whoever owns that ambulance is responsible for the patient. But if you've got an EMT basic in the back of an ambulance and you've got a more advanced air medical crew in there doing things, is that basic still responsible for what happens to that patient? So that was the bigger question.
And didn't this question come to us from the EMS committee? I believe it did, and I think their thing is who's responsible for that patient care once they pick us up.
Mm-hmm. Mr.
Sorry.
Pickering.
Madam Chair, with your permission, I think the question is a little broader in that, at least my understanding, and there's probably other folks behind me who can add some flesh to it, is if it's a non-Texas licensed air medical provider, for example, a fixed wing provider, or potentially a rotor wing provider, though every rotor wing provider surrounding should, be given a provider license under the current statutory requirements. But a fixed wing provider from Florida, say, who comes in and is providing care in the back of a ground ambulance to a patient, and then something goes awry, and then where does the line of responsibility intersect with Texas statute and regulations versus unlicensed personnel in
And
Texas?
we do have Texas unlicensed providers coming into the state, even though with the regulations that they, and I don't remember the exact number, but at some point they do have to be licensed if they do a certain number of transports. But, it's still, I'm not so sure that the air medical folks are the ones to answer that question. And it basically boils down to who is responsible for that patient in the back of an ambulance, whether it's a Texas licensed entity or somebody from Florida or California or whoever comes in. And you're right, it did come from the ground folks, but I'm not so sure I believe that that's our question to answer. And maybe we work with the ground folks to try to get the answers, but I don't think it's just our problem.
And I would comment as well, and we talked about this last meeting, that there's the Model State Guidelines project that Ames has finally got the final draft moving, that will then go to NASEMSA, the National Association of State EMS Officials, that perhaps may become a forum for some kind of a compact or some mechanism. But it's a national question that the Ames is looking at as well, and there's no easy solution at all.
Right. Thanks, Tim.
But I think the gist of it comes down that we in the air medical industry traditionally are considered a higher level of care. And definitely if we have a nurse on board, it's a higher level of care. So it's our responsibility in the continuum of care to maintain that presence with that patient until it gets to its facility.
Oh, I agree
Yeah.
with that 100%. And maybe when the new guidelines or the model state guidelines come down and have some finalization to them, maybe that will be addressed in those guidelines. And if not, then we'll have an opportunity maybe at that time to put something in there that will address it and make it clear to everybody.
Well, and I think right now, while we are looking at the rules, it would be a good time to make sure that it's addressed, as well as making sure that it's addressed within the model state guidelines. But also looking at DSHS for guidance as well on what they consider to be the appropriate care, who's actually responsible for the patient in that scenario.
Yep. And I think that's one of the places in our rules right now, and you know, some of the need to look at our rules, which we've already done, but to make sure that the language in the rules currently, to me, is a bit ambiguous. It's not really clearly defined just exactly how things are supposed to go.
Hi, my name is Jorge Sainz. I'm the medical director of the pediatric transport team at El Paso Children's Hospital. Could it be a shared responsibility? I mean, an ability to respond to that particular patient? You know, in reality, is this more like a shared responsibility concept, not who absolutely is going to have to be making the decisions for that patient, but you have two set of, of teams, both of them that have, high levels of expertise.
Mm-hmm.
Would it be reasonable to share that responsibility along with each other instead of determining or denying, well, you're responsible, you make the decision?
And you're right. And I think that's one of the things that we want to do in the rules is share that responsibility. If a flight crew is taking care of a patient, you obviously have a higher level of care. Most of the time you have a higher level of care than the ground crew that's in there. And sometimes you may not even have a ground person in the back of the ambulance with you. It may only be a driver that they send you. So, how in the world can the driver be responsible for what you're doing in the back of their ambulance? I mean, it's not even a possibility. So I think we just need to make sure that at the end of the day, that the rules are written so that everybody understands what their responsibilities are, and how we make it work so that everybody is taken care of, and that there's not liability falling on someone that it shouldn't be.
Shirley, I'd like to see us to make some recommendations, because as an RN paramedic with a compact license, if I go to New Mexico or Colorado or wherever, I am licensed in that state with my RN license, but I am not with my paramedic. And so we need to look at folks coming in, and I think that that would be a recommendation to make to Maxie's group, is to look at some kind of a model after the Board of Nursing with a compact paramedic for air, maybe just for air medical or for blanket. But I think that's something that we need to research and make a recommendation on this rule change while it's open.
And you're volunteering to help with that, right?
Of course I am.
Since you know what you want.
I do
Very
know what I
good.
want.
In addition, if the definition of responsibility is the ability to respond, how can you be responsible of responding if you're not able to respond? You know, like the example that you just said.
Sure.
As, you know, be able to drive the ambulance but not be able to respond.
And it's not just responding, it's handoff report, because you have assumed care of that patient from a facility, and you have taken report, you're taking care of that patient the whole way, and then you come back, your report or your handoff report is going to be to the accepting facility. It's not to the EMS ground crew that's providing transportation, in my mind.
Absolutely. That's exactly right.
So I think there's a whole bunch of issues.
Yeah, yeah, it's definitely multifaceted. So does that need to be a work group, or how do we need to come up with the recommendations? You know, what I would like to see happen I would like everybody to have a chance to see the model state guidelines draft at least, so that we know where that is. I know some people have seen it, but just to see what's in there first, and then take that and work from there. At least we'll know kind of where the starting point is. And I think a work group would be good.
Where can we get the draft? I thought somebody was going to send that to us.
We
Did
do
I remember
have,
that right?
yeah, we have some access to it.
Okay.
So we'll make sure we can get a copy of that to everybody. So Bert, would you like to
Sure.
head up the work group, and
Sure.
if you're interested in helping Bert, and any of you folks that want to help with that, just let Bert know. The next item on our agenda is a gap analysis comparison of the old EMS education curriculum and of NHTSA to the new EMS education standards. It's the model state guidelines, basically, and what the comparison is between the model state guidelines draft and the draft of rules that we sent in a while back, that the committee worked on for a good while. And Alicia has been working on that. So, Alicia, you want to give us a report?
Absolutely. Just for you. Okay. Can everybody in the back of the room hear me? Maybe? David? Got a thumbs up back there. Okay. The Model State Guidelines is a 39-page reference guide that goes over many aspects of an air medical program and gives recommendations to states on areas that they should cover within their rule, regulation, or legislation, depending on how the state runs their EMS. And it includes administration and management, oversight of the entire program, operational control, medical control, utilization of aircrafts, quality management. It has a safety section. It talks about your communication centers and multi-jurisdictional responses. What we have begun to do is to take this document plus the draft rule that this committee has sent forward for 157.12 and 157.13 and start looking at both of them and comparing them and see if we're on the same track, if we're on the same train. Are we going the same direction as the model state guidelines? And I'm happy to report that while we haven't analyzed each individual word to make sure it's there on both sides, a majority, in fact, everything within the model state guidelines that I've seen, with the exception, I think, of 3 things, are within the guidelines we proposed. They may be more inclusive or more detailed in some areas. Ethics would be a certain area in which the model state guidelines says you need to have a policy regarding ethical considerations. In the guidelines that were proposed by this committee, we were very detailed on how a company should make sure that they are covering those bases with ethics. Another section that was glanced upon within the model state guidelines, but we probably went into a little more depth, was medical direction. We are a medical director-driven state. There are some states that are set up differently, and they would require different medical direction needs, and the medical direction section within here is a little more broad so that it can encompass every state and their possible needs because of how EMS is set up so differently in each state. You know, when I look at things like the communications section, it's almost exactly what we had put forth. I think we drew from the same resource documents, honestly. They look almost identical. And so as we proceed forward, you know, I'm very encouraged that we are on the same track. Not only are we on the same track, we're in the same train and probably sitting next to each other in the same cabin. We are going in the right direction together. And that to me is just awesome, that we are doing that. As we go forth, I have one of the first drafts that was sent out. Want to make sure that our work group has the newest draft as we finalize this gap analysis. And what we're hoping to bring to you at our next meeting is that very detailed, this is what we've covered and written, this is what was recommended, and maybe we should include more, or we're well covered in this area, so that we can start looking at maybe adding a few more fine details to make sure that we're 100% in line. But just at this glance right now, I can tell you we're like 98% there. So I think there might be some minor revisions that the committee might want to look at, but definitely we need to bring that gap analysis in and sit down with the actual documents and look at them and get the feeling from the whole committee probably at our next meeting on what that's going to look like and where we should proceed. And maybe with our prior agenda item, maybe that would be one thing that could be discussed at that time.
Jack, I'm going to put you on the hot seat here for a second. This was, your guidelines from Ames did incorporate what we had done here, correct?
How the document came about was we met as a group and we assigned different sections to different associations. So NACS took the section on communications, ASAP took the section on medical control, and those associations wrote those different parts of the model state guidelines. We came back as a committee and we used resource documents for CAMES, the Texas draft that had come through here, some stuff that came out of California, and some other documents, but the resource documents included the one from Texas, so that's where some of that language came from. Okay. Right now, where the document is, the draft that Alicia has went back out to the participating associations, and we received a lengthy comment document back from one of them that had to go back out to the entire committee to look at to see what could be incorporated. I've done that. I've sent it back to the Ames office, and as far as I'm concerned, the final draft is with Ames staff right now to do the final grammar edits and that type of thing. So I would anticipate that being completely done, definitely by the next meeting, if not within the next 30 days.
What area was that came back with all the comments? Was it the whole document or one portion of it?
It was the whole document.
Okay.
It was acted, sent back I think a 14 or 15 page comment, agreeing with a lot of it, but wanting some stuff added to some different sections. And that had to go back out to our committee to get reviewed and see what we could incorporate into there. And that slowed us down a little bit just because that was the longest document that we got back for the comment period. So we had to send it back out. So.
Yeah, I noticed, I noticed within the document that there was a short section that did address things like subscriptions. And it did say in there that subscriptions and memberships should be addressed by the state. Was that broadened, or was there more direction given within that section? Because that is something that we did not attack based on our prior information we'd received from the Attorney General here in Texas.
I don't know that that section was changed any from the draft that you have. I would have to go back
Okay.
and look and see for sure, but it might have been tweaked just a little bit, but for the most part, it stayed the way it was in the document that you have.
Okay. So that, just for your information, it was addressed in there that the state should address subscription plans and memberships, and that advertising should be clear, and, some other things within there.
And that was some of the challenges with the document is we're trying to write something that covers the entire nation, and it's not particular to one state. So like Alicia said, some of it had to get kind of broad because the way we do things in Texas is not necessarily the way they do them in
Right.
Washington. So some of the document got broader than what it was here that we'd come up with because we were just trying to address Texas. But whenever you tried to look at other states and they didn't even have a process for something like we had, then, there's states out there that have no air medical rules at all. So even just trying to put them on some type of standard, it had to be broadened out just a little bit, so.
Good. And so, Maxie, I know our draft is still on your desk, but when these guidelines, once the draft of the model state guidelines is a completed document, and we've made our comparison to the draft that we've turned in to what they have on there and need to make some changes, additions, whatever, that we will have the opportunity to do that later on after that goes through your process, through legal, and then comes back. We'll have the opportunity to edit those at that time.
Yeah, you'll have plenty of opportunity, trust me.
Okay.
If 32 is an example, you'll have plenty of opportunity.
Okay, thank you. Any other comments on that? Okay, the next item on our agenda is the update of the status of the memorandum of agreement for air medical responders during disaster. I did visit with Rick Bays, and the draft are in legal. He said he expects those out just any time. They've been there for a while, so they're expecting those out in a very short time period. There are no substantive changes to the draft that was sent in to legal. Basically, it's pretty much going to say what we sent it in to say. As soon as that comes out and is ready for posting, Rick will let me know, and then I can get that information to you. It will be an open enrollment type document so that you can go in and sign that memorandum or not anytime you get ready to. So hopefully we'll have that. Actually sounded like we might have that within a month. So that'll be a good thing because that's kind of been on our plate for a good while. The next item is the presentation by Registry Solutions Work Group regarding recommended changes to the department's injury and prevention control rules.
Good morning. I'll just get this set up here for you. This is more of a presentation of where the registry project is at this point in time, and we'll take you through that. Morning. My name is Rob Klein. I am the project manager with DSHS over the EMS Trauma Registry Information System project. Tammy Sajak, who is the program manager, over at DSHS was unable to make it this morning, so I'll do my best to provide you with the update here. One of the things we want to try to get to the GETAC members and stakeholders, and what we're trying to do today is going to give you an update on the status and activities of the EMS Trauma Registry Project. So I'd like to discuss with you some of the current processes and accomplishments that we've made to date, and then we'll take you through a quarterly view of the EMS trauma system implementation over the next few quarters. And then we have some proposed EMS trauma system demonstration dates that we want to discuss with you and to give you an opportunity to take a look at the system and get some feedback. So we'll have those dates for you also. So where are we today? Well, first of all, we're making great progress on the project, and all of it goes to all of you, the stakeholders. So your input and your guidance has helped us greatly. We want to thank the stakeholders from both EMS and hospitals across state. You have participated in many DSHS webinars, and as we go forward and look at the demonstrations and get additional input to our system, we're hoping to get additional input and so we can go forward to build the best system possible. And also a big thank you to the members of the RSWG who have volunteered numerous hours to meet with DSHS and provide their valuable expertise to building the new registry. We look forward to their continued collaboration, and we welcome additional volunteers to join us as we continue to build the next components. We have a great partner with Consilience. Our program staff work with them on a daily basis, and Consilience has provided invaluable leadership and have an excellent working relationship with them. Their knowledge has helped us greatly in working through some of the development issues that we've come upon. From our current accomplishments to date, we have completed the trauma modeling and the data mapping of the current registry to the new, and a key part of the model includes the new NEMSIS 3.1 data elements. One other key thing that we've are looking at is we are stating go live for September 2012, and I'll take you through what the next quarters look like to achieve this. In second quarter, our key thing will be to complete our database conversion. We have over 22 million records in our old system, and we need to bring them over to the new data model. So, and the new data model also includes NEMSIS and NTDB standards. So this is quite a large undertaking. We have over 16 million EMS records and approximately 2 million hospital records within this, so it has taken us a lot of work to get to this point. Another key thing that we are building is the hospital EMS import interfaces. And these import interfaces will allow the hospitals and EMS units that have their own software, allow them, as when they upload their data, to continue that process with the new system. There'll be no changes required. They will take their same data file, they will upload it, and our interface will take that file and put it into the new registry. So there are no changes for the EMS or hospitals as far as data conversions that they need to require when we first go live. This will also give us time to facilitate us going through and deciding upon what our future data dictionary will look like, or if we're going to use NTB elements only or NEMSIS and NTB. We can get that, we can go through that. We're working with RSWG to decide upon that at this point, and it'll give us an opportunity then to publish that and get that out to your vendors who you may utilize so that they can make the changes to your software, and that will allow it to directly come into the new registry. So we're working through all those stages, and we have pieces put in place as we get there. Another key component is our validation rules and conditions. These data validation rules are built on the NTB and NEMSIS model. They have data rules and questions that are all built into the system so that we capture the correct information and in the correct manner, have the proper edits involved so that when you put data into the system, we're getting good data in and good data out. In the past, you've had to submit data and you get reports back, and some of the data was all automatically entered. We never get around to fix it. There's a lot more tighter scrutiny around what data is allowed and how it will be allowed to be entered. And lastly, during the second quarter, we plan on doing some EMS trauma system demonstrations, and we'll discuss the proposed dates at the end of this presentation. During third quarter, this is when we got a lot of the work slated, and our big goal here is to get to the bottom there where it says go to system rollout. So during third quarter, that's when we want to do a statewide rollout of the system. But to get there, we have a lot of key activities that we need to complete. First of all, we will need to get all the current registry users moved over to the new system. So we're going to pre-populate the new registry with all of the end user registry users that we have today. We have over 1,100 hospital users and over 3,100 EMS users. So we have to get all these users put in the new system and get that ready before we go live. A huge undertaking, but one that we've already started. Secondly, we are going to have some user acceptance testing, and then we're going to need to look at training. So we have planned webinars for each of the EMS and hospital and our users in the system, our current system, that we will be sending out to all of you so you can get trained on the new system. This will be a large undertaking. We're working with our vendor with this so we can get that rolled out to you just before we go live. So you'll be able to learn about the system, learn how to put data into the system. If you batch data, we'll show you how to upload system. So this will be a hands-on training sessions. And then we hope to select, when we go through this process, we'll be selecting EMS and hospitals to do some pilot testing. So we're not going to go live until you have an opportunity to go through, test system out, make sure the components work like they're supposed to, you understand how they work, and get user feedback on that from the stakeholders if we need some subtle changes or things made before we go live. So these are our key point in making sure the system will operate as prescribed. One of the components that we are working with is TxDOT. They've become a valuable partner as we are looking at them to bring in their crash data into the system. So we're trying to link crash data into the rest of the trauma registry information and use that data and analysis and that so we can put prevention methods in place for future crash data that we can utilize to help in our prevention efforts. So this is a key piece that we're also building during the third quarter. So after we go live, we'll have a system that users will be able to put their data into. We'll be collecting this data, and we're going to have some type of reporting piece there. So we'll have some ad hoc reporting where the end users will be able to build some of their own reports, and we'll have core reports already built into the system that will allow you to report on your data. We also have a facility where you can download data, and in that downloading of data, you can utilize that data yourself to do your own type of reporting that you require. Now, over the next few quarters here, we're going to be coming back to you from a stakeholder viewpoint and asking you, what are your priorities for reporting? What type of reports do you need from the system? We've looked at all of the old reports in the old system. Some of them are relevant, some of them not. We want to get some feedback from yourselves as to which reports you would need to do your business. So we want to take those, and in some cases we can build those ourselves. In other cases, we're going to need to help our vendor to build some customized reporting. So around that, we're going to have some priorities based on that and bring customized reporting back and build those during the fourth quarter. And during the fourth quarter, we're also going to roll out a registration enrollment portal. This will allow facilities, new facilities mainly, to come in and manage the process of getting registered into the new system, managing your end users, setting up administration accounts, using roles and groups within your facilities, so that can be all done automatically by yourselves. There'll be some verification processes in there for DSHS to check, but mainly it'll be all within the privy of the facility. And once this also comes in, facilities also have administration and roles and accounts in there. We'll also be able to update those themselves. They won't have to go through DSHS. It'll be automatically. We'll have end user agreements within there and how the data should be used, data sharing agreements. All this will be automatically in digital format, so you'll be able to see those. You also, the end user will get training through this new web feature. So it takes a lot of the manual process that we have now today and puts them in the hands of you, the end user, and the stakeholder. So we're going to get to rollout and end of third quarter. You're going to start using this new system, and we want some user feedback on this. And like any new system, not everything is there at once. So we're going to actually ask you for your feedback, get input on how the system works, if there are changes required, and then do analysis of that. So we want to get that feedback from you, the stakeholders, and internally from our DSHS teams, and we want to then change things where we need to or add additional features and components, and so we get to enhanced version number 2. And we want to do this throughout the first quarter of 2013. So what's next? So EMS trauma, we want to do some registry demonstration. We're proposing 2 dates at this point in time, June 5th from 2 to 3:30 and June 7th, a morning. We're looking at how we're going to do this. We're trying to decide if we're going to do this, have some on-site and also webinars, have this webinared. So for those that are outside of Austin or throughout the state, so we'll give everybody an opportunity. These are the first 2 dates that we've kind of proposed at this time. We believe we'll probably need some additional dates, so we'll get feedback from you and what you would like to see from a demonstration point, so we can work it, so we get get your involvement, and so if there's any things that you need changed, now is the time to do it, and we can gather this information. Any questions?
And these will both be webinars?
These are both webinars, yes.
Okay, and we'll get that information?
Yes, that'll be going out to all the GETAC committees, plus all of the stakeholders and RSWG groups that we have now work with.
Okay. One of the things I think I heard you say was that you were going to be looking at changes to software, or people would need to make to their software or something, so that the information would automatically dump into the registry? Right.
There's right now, we are building some what we call legacy interfaces for EMS hospitals that that send their data in now. So today they have vendors who have trauma software systems, and that data gets uploaded into the registry as it is today. We're keeping that interface so that you can continue that same process, and that data will automatically get brought into the new registry system. Now, over time, there's talk about moving into the new data elements, NEMSIS, NTDB, and what does that look like? And there's a group now that we're getting together to look at that kind of data dictionary. And the reason for that is there are some decisions have to be made around which data elements we are going to select in the future that will get pulled into the new registry model. Now, that has some implications for the EMS and hospitals that have other vendors out there that utilize their systems, because they're going to have to change their software to meet whatever this new requirement is. And when we get consensus on that, then we will give them the file formats and the data dictionary that we've agreed upon, so that instead of using these legacy, they can directly send that data in. So that's kind of the work we're trying to do. It's a kind of the future piece that will probably come after we go live and into probably 2013, but there's a big push by the different GETAC groups that have different vendors that they're trying to budget for this for 2013. So the key thing right now is trying to get that data dictionary. We've heard our stakeholders this week. They want to get that done, completed as quickly as possible by the end of June, so they can take this and have it ready to have their vendors take a look at it, so they can size the amount of work they have to do and get their budgets in place. So this isn't something that's going to happen through calendar year 2012, but it is something we're trying to get ready for 2013, 2014. We're working through the GETAC community here to decide upon when's the best time to do that. But right now, the big push is to get some type of idea what the sizing, so people can get this money put into their budgets for 2013.
Okay. Well, I can tell you, there's not a whole lot of areas that I can tell you that our neighbors to the west are ahead of us as far as EMS and trauma services go, but having the registry there that our software automatically dumps into truly is very nice. At least to feel like we get more accurate information, and being a user of that system, I can go in and pull reports that are just, it's incredible the information that you can get out of there. So, there's probably, and this is just a guess on my part, but I would say there might be 2 or 3 major software programs that the air medical providers use.
Right.
So maybe it wouldn't be too difficult to get that to happen. It really is a time-consuming process to sit down and hand enter all of that information into the registry right now. So, just from a personal standpoint, I can tell you I don't think we have very good information in there, because I think there's a lot that's not put in
Right.
that would automatically be entered if you can get that set up. So I would encourage you to make that a priority for us.
Okay, that'd be terrific.
Tim?
Now, I applaud the effort to automate and make the system seamless. However, as a stakeholder at the air medical side, I have some really sincere questions about, I hear a data dictionary, and then you're going to have software requirements for our vendors that they're going to have to change the software. Is the state going to then fund those changes to our contracted software?
We do believe that the state will not fund that software changes. The key thing here is that there is a move to a national data standard, and to move to those national data standards, those vendors are going to have to make those changes anyway. And the hospitals and EMS are now looking at that, and from the groups that we've heard back from here through GETAC, they're asking now for us to look at that in a serious way, so that those national data standards can be decided upon, because right now is it NTDB, is it include NEMSIS, and do they want components that are already in the registry also included? And that has not been decided. And the key problem we're having right now is that until that is decided and a data standard model is picked that we're going to use as our data dictionary, the vendors cannot size or take a look at how much work it's going to do to change their software so it can collect that data, or make sure it's collected.
Okay, I hear you, and I'm very familiar with the national data effort, and there's a tremendous amount of problems, particularly with NEMSIS 3.0 and air medical services, and the expansion to 16,000 ICD-9 codes. It's a wonderful understanding from your presentation, but I think the problems are much more complex and much deeper than are being portrayed here. And I think at a national level, what is decided nationally, and then the states decide to individually morph and select, won't work with our vendors. So I think we've got a lot of work to do, and I encourage you to stay in tremendously close touch with the members of this Air Medical Committee and the stakeholders they represent, and the software companies that they are funding and contracting for electronic data collection, because I can tell you that some of the software vendor changes are not going to be insignificant, and they're going to be very, very costly. And as a stakeholder group, we may not be willing to fund those.
Okay, I understand. Just to make a point, we're not trying to push to the new data standards or whatever we decide upon right away. That's why we put these legacy interfaces in, so we could capture your data the same way you're putting in today, move that process, and so we keep things as normal as possible as we go live. There'd be enough work around learning a new registry and how the registry is working and the additional components we have to build throughout this year. We weren't looking at implementing that until 2013, 2014. There is a push in some of the hospitals and EMS units, though, that want to get this pushed along further, so there has to be some discussions around that, and they want to understand what their cost structure is right now, so they can take a look and see if they can actually afford to put this into their budgets for 2013. But thank you for the question. We are very concerned and looking at this and trying to work through this. So we know it's not a small issue.
Sure. One of the other questions I know that was brought up last night that we didn't get a chance to ask at the trauma committee meeting was how are you planning, or you need to let us know, I guess, how you're planning to keep up with the annual updates with NTDBS so that you'll be able to ebb and flow with that, so that we don't have this cost every year. Because I share his concerns. I know that we're working with DI at Del Sol, and our RAC registry is also through Digital Innovations. So, this is potentially a very huge cost for us. So I think that we need to have those answers prior to moving forward.
I would agree with you, because just trying to keep up with the different NEMSIS. We're at 3.0, then we're 3.1. Part of the issues that we had even with this project and doing our data modeling, our data mapping, was when do we, what point do we, get on with selecting the data standard at that point in time? Because
you have to be fluid, though. You can't select this data standard because every year NTDBS upgrades and every year MSIS upgrades. So you need to be a fluid system that can do that.
I understand, but to be fluid, there's a cost to that also, and you also have a cost to each of your providers and your vendors out there. And there has to be something where we all kind of make a change at a similar time. We're going to have to be, I understand being fluid, but not everybody can afford the cost to move immediately when those new standards come out. So just trying to put it in phase where we're now working with NEMSIS 3.1. There'll be a new NEMSIS coming out. We don't expect to move that until we have until this registry has been operating for a few months or a year before we go to the next data standard. Just because it comes out, I don't think everybody can move that quickly. I mean, it takes a lot of work. If your vendor can, that's great. We'll work with the vendors and work through that. But we'll be in lock and stage with that, but it's going to take time to work through that process. Any other questions?
Anyone else? Thank you very much.
Thank you.
Appreciate the information. It's time now for general public comment. Welcome to the microphone.
Justin Boyd, EMS Committee. Discussion about the previous topic being between ground and air. Maybe another concept or way to look at it would be, while I appreciate that we're going to look for tomorrow and where the rule changes are going to take us to make sure we get this right, especially for patient care, maybe there needs to be consideration about what the rules currently are, because listening to everybody and having conversations, nobody really understands or interprets them the same way. There's a wealth of information that sits at this table, and as y'all visit, everybody has something different. I'm not saying any of them are correct or wrong or waiting for a response from the state, but there's different interpretations in different parts, and I think that the rules apply to the entire state and to each provider that's licensed in the state. And maybe look at it that way and see what the definitions you come up with, and that will help lead us to where we, or how we need to change the rules for tomorrow. Because when I ask, I get a different interpretation most every time.
So,
Good point, thank you.
So, Justin, just a second. So maybe, are you looking for maybe a broad position paper that outlines some general things? If you're generally in this position that an out-of-country crew is in the back of your ambulance, or an out-of-state non-licensed, or an in-state licensed, these are generally how things should flow. That would come from the state. I mean, we can absolutely make recommendations, but in the end, the person who's going to be enforcing it if something goes bad is DSHS.
Exactly, and that's kind of the purpose behind the conversation, is that we don't want somebody to come in behind us and say, well, you did it incorrectly this time.
Right.
They want to look at them on a case-by-case basis, and I understand that, but I would prefer and I would ask that we be able to recognize the deficiencies so we can tackle them, so we're not investigated by the state and we're doing it correctly from the start, as opposed to having to be retroactive.
Is that something that the state can do? Can define some things out there generally? I mean, work with us, work on the side, and maybe put a position paper out?
I think one of the things that will help with that, with our draft rules that we've done, I think we paid pretty close attention to some of the parts in the old language, old rules that we felt like were somewhat ambiguous and open to different interpretations, and tried to more clearly define those in the new rules. I'm sure we didn't get them all, and we may be wrong on some of them. Hard to believe, but anyway, that, I agree with what you're saying. I would like to have the rules as clear as possible and open to as little interpretation. I would like everybody to be able to read the rules and come up with the same interpretation, as closely as possible. And if we get to a point that, we've got something that we feel like isn't clear and we have different opinions of what that really means, then we take it to the state and get their definition of what that rule really says, and then make sure we have it in writing. It'll be a long process, and I understand that, but, it's not something that's not doable.
Along those lines, as Ms. Worden has just set out 3 kind of sample thoughts, and this committee in the past has gone to DSHS and asked for an advisory opinion on particular matters, so that there be some guidance from DSHS on particular sets of facts. Fact, out-of-state fixed-wing program transporting a patient inside a Texas licensed ground ambulance. That's a set of facts. What is DSH's advice, so that you get an actual opinion, which I think is what you're talking about, but maybe we can help the process move a little more quickly by asking for that, and then Mr. Jansky or whoever is assigned to it could then work with DSHS to craft an opinion that could be published for everybody.
Is that maybe something that we can do as a joint EMS Air Medical meeting? Have maybe 1 or 2 people on both committees participate in a work group to bring something to the table, so that the EMS committee and Air Medical committee can sit down, and maybe even the medical directors, since their license is on the line there too, to really hammer down what we would like defined, and ask for that opinion, the advisory opinion.
We'll certainly reach out to the EMS committee and the medical directors on this work group to see that we can get representation from everybody.
How y'all doing? Brock Miller with Air Medical. On behalf of Thames, I just want to invite everybody here to the Texas EMS Hall of Honor Annual Golf Tournament. It will be held Friday, November 9th at Onion Creek Country Club here in Austin, Texas. It'll be a 1,300 shotgun start, 125 a player, or 400 a team. And you can register at thames.org. And if you received a save the date from me last year, please shred that. That was with the old Texas CMS conference date, so all those are not applicable anymore.
And what was the shotgun start time?
1,300. And all proceeds do benefit all the families of the fallen.
And the new date is?
Friday, November 9th. Thank you.
Okay, thank you, Brock. I know I didn't get to play last year, but I think everybody that did had a really good time. I understand it's a beautiful course, so we would ask everybody that can to come out and support that. Anybody else?
On that line, we're working on a memorial video to go along with that. If you're part of an organization or have known somebody who's fallen in Texas in the past and is on that Wall of Honor, if you could email me or Brock some information about the person, newspaper clippings, family pictures, things that we could add to that to expand it and really celebrate the life and the contribution that they made to our profession, I would truly appreciate that.
Thanks, Alicia. Okay, any other announcements? Anybody? Okay, so at our next meeting, we will table the items on the acute care language to go into the Texas Administrative Code until we have a little better handle on what the rules are going to look like in the future, and then we'll work on that when the time is maybe a little more appropriate. The patient care issues for EMS ground and air providers, both being present. We have put together the work group. Roberta is going to head that up. And we'll probably be asking some of you folks to help with that, so I would encourage you to do that. We will make sure that we include EMS ground providers, medical directors, anybody that would have a stake in that. Certainly we'll be asking to join in that process. The draft of the model state guidelines, Alicia's report that we are, some items are more detailed, some less, but it looks like we're about 98% on track with that. We'll continue to watch and compare, we'll get the final draft and look at that. The memorandum of agreement for the air medical responders should be out very soon. Open enrollment, and I'll let you know as soon as we have that taken care of. Ongoing work on the registry, so we'll be watching for the changes in the notifications on that and the training, the webinars. Anything else? Okay, our next meeting date will be, our next GETAC meetings will be August 15th, 16th here at this hotel again. And don't forget that the EMS conference has been moved back 1 week. So it's now the week before Thanksgiving this year instead of the week of Thanksgiving. Thanks to NASCAR. I'm going to send them a letter of thank you myself because I really, really like that. If we have no further items or issues, we are adjourned.